to introduce our esteemed speaker, Dr. Ng Phay Seo. Dr. Ng is currently the Manager of Strategic Planning and Innovation at Premier Integrated Lab, Pantai Hospital, Kuala Lumpur, where she's making a significant impact through her leadership in digital pathology transformation. A dedicated and visionary leader, Dr. Ng is known for her innovative approach and collaborative spirit, playing a pivotal role in securing the prestigious TUBITAK MITE Collaboration 2.0 Grand Challenge Grant. In this capacity, she coordinates a 3-year project that has stood out as one of only 4 winners among more than 80 impressive applications. Dr. Ng's journey in cancer genetics began with her doctorate at the Faculty of Medicine, University of Malaya, where she explored the association of PALB2 variants with breast cancer risk and the molecular characteristic of PALB2 tumors. Since January 2023, she has applied her scientific expertise and strategic insights to Premier Integrated Lab, where she collaborates closely with academic, government, and private partners to evaluate and implement new technologies, improving lab processes and enhancing quality. Today, Dr. Ng will be sharing her insights on digital pathology, a transformative field that is shaping diagnostic practices and laboratory operations. As Dr. Ng presents, please feel free to jot down any questions. We'll have a Q&A session at the end of her talk, where she'll be happy to address them. You can also type your questions in the chat box, and I help moderate at the end. Thank you all for your attention, and without further ado, please join me in welcoming Dr. Ng Phay Seo. Dr. Ng, the floor is yours.
Hi, good afternoon, everyone. Can you hear me?
Yes, I can.
Can, yeah? Okay, that's good. Yeah, thank you, Ms. Veena, for the kind introduction. So as mentioned by her, I'm part of the Strategic Planning and Innovation Unit in PIL, yeah. And one of the main roles in this unit is that we constantly look for new technologies, evaluating and adopting them to improve the work processes within the lab to ensure that we can always provide high quality laboratory services to all our clients. So as mentioned, I'm currently leading the digital pathology transformation journey in PIL, and also leading a few collaborative research projects with academias and industry partners. So before I begin, I would like to thank the committee of the Association of Scientific Officers, Ministry of Health, for inviting me to give this talk on the topic of digital pathology, as well as to share with you PIL's journey on this. I must say that our journey is definitely an ongoing one, but before dwelling further, let me just give you the content of my talk for today. Yeah? I'm aware that all of you are from various backgrounds. Therefore, I'll be delivering a high-level and broad overview of digital pathology for the benefit of the diverse audience that we have. So today, I'll be covering on introduction, the key features, as well as requirement for implementation of digital pathology, and benefits of digital pathology, as well as the barriers and challenges, our experience in digital pathology, particularly in the field of anatomic pathology. And I will be also talking a bit about the future trends that we can see in digital pathology. So as many of you will agree with me that pathology is the foundation of healthcare and is responsible for providing accurate and timely diagnosis of patient samples, which ultimately guide clinicians on the best and effective way to treat their patients. So traditionally, as most of us know, pathologists have been using glass slides and microscope to examine tissue and fluid samples. While this workflow has been persisted for many years, it does have certain limitations, such as the need of storage space to store all these physical slides, glass slides, right? And manual sorting and transportation of these slides. Also, limited access to expert pathologists in geographically remote and resource-restricted area. These are some of the limitations that we can see with today's workflow. So to address these challenges, innovative technologies are increasingly being adopted by pathology labs to provide better way to improve their workflow and ultimately to improve patient outcome. And digital pathology is definitely one of them and currently is gaining momentum worldwide. So what is digital pathology? It is actually a system that converts glass slides of pathology specimen into high-resolution digital image that can be viewed, shared, and analyzed on a computer at a magnification that is comparable to a microscope. Meaning if the microscope can magnify to 40 times, digital pathology system can also magnify a glass or digital slide image to 40 times or more. And some system can even magnify it even higher magnification at 60 times, 80 times, or even 100 times. So there are essentially actually 4 key components of digital pathology system, and it comprises of the hardware, software, network, and IT infrastructure. And each part of this is important to ensure the success of implementing digital pathology and ultimately to be used by the end user, who's our pathologist in the clinical setting. Therefore, having buy-in from the pathologist is very crucial in this for the success of digital pathology. Yeah. So the heart of the digital pathology system is actually the automated whole slide scanner, which is the main image acquisition device. There are many brands and different out there currently right now with different features, capacity, and throughput available for different intended use. The next few slides, I'll be showing you some examples of scanners that are commonly used worldwide and also available in Malaysia right now. So each scanner has their own strengths and limitation, and currently there's actually no perfect scanner that can fit all intended use in the lab. Therefore, selection of appropriate scanners depend on the specific laboratory requirements. So Aperio is actually one of the famous brands which are currently being used worldwide, and also one of the few brands that have FDA approval for primary diagnosis. So you may ask, what is primary diagnosis? That primary diagnosis simply means diagnosing a case solely based on digital slides without the need to refer to glass slides. So the downside of this brand is that currently they only have one model available, which has the capacity to scan up to 450 slides per batch. And the cost of this equipment is close to 1.5 million. This is as of last year. But fortunately, I heard news from the vendor that they are coming up with a lower capacity, lower throughput model that is 180 slides, somewhere end of 2025. It probably will reach Malaysia by then. So the current local distributor for Leica Aperio right now in Malaysia is HistoCenter. I believe those who are familiar with the histology vendor who supplies histology equipment, you'll be familiar with HistoCenter. So next is Roche. Roche also provides a digital pathology solution, and currently they have 2 models of scanner. The first is the 6-slide scanner, currently widely available in Malaysia, and recently they just launched a 200-slide scanner in Malaysia just not too long ago, just recently, I think just a couple of months back. In addition, they also have a suite of AI algorithms available for use with their scanner to interpret IHC stains, but their algorithm are closed system, meaning they are only applicable for IHC slides using their Ventana reagent and autostainer. Next is the 3D Histech. It's a digital pathology company which has been around since 2005. It carries a wide range of low to high throughput scanners, from 1-slide scanner right up to 1,000-slide scanner. So if a lab needs a scanner for frozen section purposes, meaning to do intra-operational consultation, frozen section, so they can consider getting a 1-slide scanner. Or if the lab wants to digitize all the routine H&E slides, then they may have to consider high throughput units such as the 480-slide scanner or the 1,000-slide scanner. And of course, the higher throughput it is, the more expensive it becomes. And the current local distributor in Malaysia is Inov Sdn Bhd. Next is scanners from Hamamatsu, Japan. And this brand has 3 models, and which can scan 20 slides, 60 slides, and 360 slides. And some of these models can actually be upgradable to even scan fluorescence slides here. And the current distributor for Hamamatsu in Malaysia is Metric Optics. Of course, not forgetting, there are many other brands that are coming from China as well now. And more distributors are carrying China brand, including KF Bio, which is now being carried by Cube Scientific in Malaysia, and Canadian scanners, which are being carried by Peto Intel. They have already reached our shore. Yeah. Okay. So far so good. Is everything okay? Yeah. So far so good. Okay. Good. Let's continue. Yeah. Yeah. I just want to make sure I'm on the right track. Okay. So the other important hardware. Sorry, let me put on the pointer. Okay, so the other important hardware required will be for digital pathology will be the high computing workstation. When incorporated with the appropriate software, will enable users to be able to view, manage digital images, and even use as decision support tools for analysis. And also not forgetting, in order to have seamless workflow, it will require high speed and stable internet network, which could be a barrier to some organizations, especially those that are located in the rural areas with limited access to internet. And of course, not forgetting, it also requires a robust IT infrastructure to support integration of digital pathology system into the pathology workflow, including integration with the laboratory information system and to the server, as well as providing storage system to store these digital images. Just for your information, each of these whole slide image or digital image, we call it, has a file size between 0.5 gigabyte to 2 gigabyte. And this is really very much depending on the size of the tissue that we scan or the area of scanning. Yeah. So you may ask, how much of storage space that we need to prepare for if you want to implement digital pathology in the lab? Yeah. So here it's just a simple calculation to estimate the storage space required. Say for example, lab A is scanning on average 200 slides per day. Yeah. And if you consider the size of image is at 1.5 gigabyte, lab A will be generating 300 gigabyte worth of data on a daily basis. So if lab A is required to store data for at least 5 years, hence lab A will need to prepare for sufficient storage space of 540 TB even before they start implementation. Yeah, this is how much data that space that required. Here is just a recommended retention period for digital images for histology and cytology according to the guidelines developed by College of Pathologists together with Academy of Medicine Malaysia and Ministry of Health Malaysia. Unfortunately, there is currently no concrete guideline so far. So this is the nearest that we could refer to for now. Yeah. So according to the guideline for histopathology digital slides, the minimum retention period is 7 years, similar to the number of years that we need to store the glass slides. Of course, there are debate going on. Some people would say that, some labs will say, if you have the glass slide, why should we retain the digital image? So there are two schools of thought. Some will say you need to keep both. Some will say you can keep either one. So currently, as I say, there's no really concrete guideline that we can follow. But of course, for some of the organization, most of the organization, they will try to keep as long as possible. Because once you have this digital image, you might need to use it for future to input into the AI algorithm one day. But yeah, if you don't have the storage space, then probably then you have to drop the idea of storing for maybe more than a year. But for cytopathology, digital image is recommended to keep for 6 years, especially those that you have been using to input into the AI to screen images. Yeah. So what are the benefits of having digital pathologies system in our laboratory? Firstly, it allows pathologists to work remotely, meaning working from any location and to have a more flexible working schedule. Also, this also enables the pathologists to be able to refer cases to their other colleagues, probably for discussion, or in the event when they are sick or having vacation leave, and also allow them to refer their cases for second opinion from the experts. Yeah. Secondly, it allows enable the pathology labs to maintain operations even during the public health emergency, such as that of the COVID pandemic that we had a few years back. Yeah. As we all know, cancer cases and pathology requests are always on the rise, whereas the number of pathologists are reducing by the year. So having digital pathology system in place can actually prepare lab to be ready to adopt AI-based diagnostic assessment tools in the near future. And with these tools, it will enable pathologists assist them in diagnosis, providing more accurate and consistent results. And with proper integration, these clinical support tools can actually help to improve and standardize workflow, eliminating simple error, increase reproducibility, and improve diagnostic predictions compared to conventional method. So, despite of having many advantages of having this digital pathology system, there are also many challenges that comes with it. And the most significant one will be the initial high cost associated with the components to set up the entire DP solutions, as mentioned in my previous slides earlier. So in addition, it also requires workflow modification in the lab processes, as good preparation of slides is critical to ensure successful image acquisition and interpretation. Image quality is crucial for pathologists to make an accurate and confident diagnosis. Simple changes on how we prepare the slides can ease the adoption of digital pathology and demonstrate many of its benefits. So here is the table which I actually borrowed from Leica Biosystem that highlights the areas where we can improve on to prepare good slides. So firstly, we start with embedding. So a good practice is to cluster and align samples near to each other, but not overlapping, so that you can minimize the scan area. And hence, with this minimal scan area, it can minimize the size of the file during scanning. Yeah. And during microtomy, meaning sectioning of the tissue, always try to avoid folds or tears or line on the section. And this also, we also need to ensure the consistent thickness of 3 to 4 micron on the entire section to prevent out of focus issue during scanning. So if, let's say, for example, you have a fold at one area, it may cause out of focus when you try to scan the slide using the scanner. And the other thing that we need to also be aware that during the fishing of tissue section on the slide, you need to ensure that tissue must always be placed right at the center of the slide and not towards the edge, at the edge, where it could fall at the no scan zone area, which can result in failure to properly scan the tissue completely. In addition, slide labeling is also very important. We need to always ensure that slide labels are positioned correctly, such as here, and not protruding out like this, which may interfere with scanning and can even cause the slide to get jammed inside the scanner if not careful. Yeah. So in PIL, we have already started using laser slide printers to automatically print directly on the slide upon scanning barcode of the cassette. This eliminates the step of attaching slide labels manually. Next, of course, we must always ensure that staining protocol has to be consistent and to generate standardized staining intensity throughout. Yeah. Last but not least is cover slipping step. Cover slipping step is very crucial. And for digital pathology practice, it is strongly encouraged for us to use automated cover slipping to prevent formation of bubbles and also to prevent excessive DPX at the edge of the slide. Because if it's not, if you have too much DPX, it will also affect the scanning. Yeah. And before we put the slide onto the scanner, we must always ensure that DPX is dried and completely before we put on the scanner. If not, it will also cause error sometimes during scanning. Yeah, so currently in PIL, we are actually using film cover slipping. And this has actually helped a lot to eliminate most of the issues that can affect slide scanning that I've mentioned earlier. So apart from workflow modification, other issues that could be barriers and challenges to adopt digital pathology are all these technical challenges such as hardware, software, and network glitches every now and then. And difficulty, especially difficulty in integrating digital pathology system with LIS, can also be a pain. So ongoing support must then be provided to users, especially by IT and vendors, to ensure technical issues are promptly addressed to minimize downtime. And in addition, we also require careful planning to carry out validation before using digital images for diagnosis purposes to ensure patient care is not compromised. Also, pressure to meet turnaround time for reporting and unfamiliarity make it difficult for users, especially pathologists and lab personnel, to adopt digital pathology at initial phase. Usually when we have new things, it's really hard to get people to start using because of unfamiliarity. Most of the reason is because of that. Yeah, of course, also lack of regulatory in Malaysia means having no guideline to refer sometimes also makes things quite difficult. And finally, data privacy and security concerns. So for the successful adoption of digital pathology will require full support and buy-ins from numerous parties, not only with the pathology department, but also across the organizational wide, including the higher management, the finance team, the procurement, as well as the IT department. So this table basically summarizes the requirement and cost estimation for adoption of digital pathology. Here, I just want to highlight to set up a digital pathology system in one location, one site, will require at least 750,000 ringgit Malaysia. And this is minimum, yeah, which is a fairly significant amount of investment to put in. So let me now share with you one of our PIL's initiative in introducing digital pathology service in IHC workflow. But before that, I would like to introduce you to Premier Integrated Labs. So PIL was formerly known as Pantai Premier Pathology, as most of you may know, and was first established in 1997. That was 27 years ago. It is currently actually the leading medical diagnostic laboratory offering comprehensive range of laboratory services in Malaysia. And the lab service that we provide includes all the routine as well as specialized testing. As PIL is part of the IHH Healthcare Berhad family, hence we provide service to all IHH hospitals in Malaysia. We also serve other GP clinics and other non-IHH hospitals as well. We were recently recognized as the Diagnostic Provider of the Year in Malaysia by the Healthcare Asia Award 2024. In total, PIL actually has 34 labs across Malaysia, both Peninsular as well as East Malaysia, with the latest lab being set up in Timberland Medical Center. Of the 34 labs that we have, 9 has histology facility, whereas 6 has cytopathology facilities. And currently we have a total of 11 resident pathologists and more than 20 visiting pathologists covering all major pathology specialty. So what is IHC? For the benefit of those who do not know, IHC stain is actually used to detect protein markers to assist in accurate classification of tumor and diagnosis in histology. IHC results are typically required promptly to make treatment decisions for oncologists to treat their cancer patients. So in PIL, IHC requests are mostly being run in the central lab, which is the HQ located in Pantai Hospital KL. PIL in PHKL is currently processing about 45,000 IHC slides per year, and this translates about 150 slides per day, and running using 4 fully automated IHC auto stainer to run, which includes 2 Benchmark Ultra and 2 Dako Omnis. Currently, the lab is running more than 170 different types of IHC markers. For your information, in the private setting, these stains are chargeable to patient. Hence, pathologists must be very careful to select only the appropriate stains that they require to assist them in their reporting. So at present, most interpretation of IHCs by pathologists are done manually via observation under glass slides under the microscope. Currently, only urgent IHC slides are being scanned for digital slide viewing. PIL is actually in the process of trying to implement full digitization of all IHC slides for outstation branches. Currently, we have 2 scanners available in PHKL, Bangsa. The first is 3D Histax Scan 2, which is a 150 slide scanner, and Roche DP200, which can scan 6 slides per batch. Okay, so this is the diagram that compares digital pathology workflow and non-digital pathology workflow, which is the conventional workflow. So in the usual conventional non-digital pathology workflow, once the unstained slides are prepared and sectioned, the slides will then be placed onto the auto stainer to be stained. Yeah, when the staining is completed, the slides will then be sorted out manually, and then it will be packed to be delivered back to the respective branches, which may take up to 3 days, especially to branches that are located in East Malaysia. So pathologists can actually only review the slides after 3 days. And in the event, if they want to add on stains, they will have to wait for additional days for the slides to reach them. Whereas for digital pathology pathway, as soon as the stained slides are ready, they will be put on to be scanned, and within less than a day, the pathologist would be able to review their slides remotely. From here, we can already see that with DP, there is significant shorter turnaround time for pathologists to view the IHC image and to request for more IHC stains if required. Hence, this helped to shorten the reporting time, allow reports to be issued much earlier compared to the conventional way. So what are the advantages of digitizing IHC slides? Here we can see that the first thing is that we are able to access and analyze multi-slide digitally. The advantage of having digital images are you can actually align them side by side. Say, for example, this H&E of this core biopsy right at the center is aligned together with other IHC slides that were stained with different markers. And at the same time, you can sync them together and you can zoom in and out to view them at the same time concurrently. And it also allows you to zoom in and out to target or to select any region of interest that you want to view at cellular level or different magnification. And you can even take pictures and snapshots of the cells, and also do measurements if necessary. And making measurement is something that is a task that is difficult to do on glass slides, yeah, as we all know. And previously, IHC assessment were quite straightforward, whereby pathologists will just need to report whether the stain is positive or negative based on the staining outcome. But now it has become more and more complex and also time-consuming. And because of this, having AI tools to interpret IHC will be a very good support tool for our pathologists. Here are just some examples of the current available AI and machine learning approaches available for tumor analysis which a pathology lab could potentially adopt. Yeah. While many manual scoring and identification of these above parameters may only take a few minutes by an experienced pathologist under the microscope, it can be made more efficient and reproducible by an automated method. The AI tools could assist pathologists to automate tasks that are time-consuming, hence speed up reporting time, perform quantitation more objectively, and increase diagnostic accuracy. So I like to emphasize here that implementing AI tools in the pathology workflow is not meant to replace pathologists or any lab staff, but it is to support and to assist. And at present, the digitization in PIL histology section is implemented only for IHC slides, as well as some of the special stains. And eventually, we would like to roll out to include other routine histology slides. With this stepwise approach, we hope to allow users like pathologists and lab personnel to first familiarize themselves with DP system before the full rollout. Next, we will switch gear to cytology section to showcase our initiative of using digital pathology and AI in cervical cytology screening. Up to 95% of samples that receive in cytology labs are related to cervical cytology screening. So cervical cytology screening is an old but reliable method and still being widely used today. It is to detect cervical cancer, precancerous cervical lesions that may progress to cervical cancer. And we all know that cervical cancer is completely preventable and curable if precancerous lesions are identified, diagnosed, and treated at early stage. Traditionally, cervical slide screening requires manual identification of abnormal cells under the microscope. Therefore, it requires highly skilled cytotechnologists, cytoscreeners, and it can be time-consuming. It is very tedious and labor-intensive. Also, some highly subjectivity due to the inter-observer interpretation, because this really very dependent on pattern recognition of cells and require a lot of experience from the cytoscreeners. Therefore, the ongoing process of slide screening will eventually increase burden on the cytoscreener as well as pathologists, with increasing workload over time. This will possibly result in inefficiency and inaccuracy of screening in the long run. Currently, the PIL PHKL cytology lab in HQ is processing close to 75,000 slides per annum, which translates to about 250 pap smear slides per day. And of this number, 75% of them are LBC, whereas the other 25% are comprised of conventional pap smear. Currently, the available AI algorithm is designed and optimized to evaluate digital images of liquid-based cytology samples only, for your information. So the digital pathology system and AI algorithm, this system is from China, was placed in our central cytoscreener room in Pantai Hospital KL for demo and evaluation in mid-2023, whereby we actually did 2 evaluation studies on this. The first is a concordance study using 705 retrospective samples, and second, the clinical validation study, we used 1,266 prospective LBC samples. Both studies demonstrated that digital pathology with AI-assisted screening approach is beneficial due to its high sensitivity rate and while allowing efficient automation of tedious tasks. While this system is sensitive to pick up abnormal cells, however, it still requires further retraining of the AI algorithm with more local samples to achieve more accurate predictions, particularly on the detection of microbial infections. This figure shows the comparison of workflow between the conventional method and the DP workflow. So in conventional workflow, it requires 2-step screening by 2 independent cytoscreeners, followed by reporting by a pathologist or a senior cytoscreener. Each of these steps actually require careful microscopy observation by well-trained cytoscreener and pathologists, and each step probably take close to 5 minutes, on average 5 minutes. Whereas for the digital pathology workflow, It encompasses digitization of LBC slides using high throughput scanner to generate the whole slide image, followed by automated screening of the image by the AI analysis algorithm. And next, followed by digital review by Cytoscreener on the AI analyzed output. The digital review here referring to the AI-assisted review approach, which combines the AI analysis with human evaluation. And last but not least, followed by final review and signed out by Cytoscreener or pathologists. The aim of this digital pathology is to digitize physical slides and to use AI-assisted screening algorithm for efficient automation of tedious screening tasks, mostly to replace the role of the first screener. So what are the advantages that we see if we use AI to help with the screening tool? We can see that it helps to improve the sensitivity in picking up abnormal cells, as well as improve efficiency of screening as it is done more objectively, even long periods of time, as AI do not feel tired over time. So we can go on and on no matter how many slides we feed for the AI to screen. And another advantage is also it enables archival of positive cases to be used for prospective training materials. Yeah. So the next few slides, I'll be showing a quick look at the AI software. This, as I mentioned, this software actually originates from China, and this is just a main overview page. Here, it shows the overall task status. For example, to show how many cases have been created, the number of cases scanned, and number of images waiting for AI analysis. And the bottom here just show overall overview of number of cases, number of active users, or tasks created, and WSI storage usage, or number of review tasks. On the left here shows the statistic of number of cases reviewed by AI over months. Yeah. And bottom will show the number of cases being reviewed by each Cytoscreener. And on the right here, you can see it shows the QC status of the slides being scanned, showing the quality as well as the quantity. And bottom will show the distribution of type of cases being reviewed. This is just an overall snapshot. And this picture I've taken before we started to do the evaluation. That's why you see the numbers are very low here. This is the Workbench tab that shows all the cases assigned to a particular staff. These cases have already been scanned and also being analyzed by the AI and have been given the suggested grading by the AI. They are all ready for the Cytoscreener to click review and for them to review these cases. When the Cytoscreener click on the review icon, it will open another tab which shows the particular case which has already been analyzed by the AI. And it will show all the region of interest on the right hand here, where the Cytoscreener can actually click on every one of the ROI to magnify it, to look at the cells at a higher magnification, and to confirm whether the diagnosis proposed by AI, whether they can agree or whether they want to override the diagnosis called by AI by feeding the correct diagnosis deemed appropriate by the Cytoscreener after reviewing all the region of interest. And this is how the Workbench tab will look like after the cases have already been reviewed by the Cytoscreener. So back to the question of where we are in the digital pathology transformation journey. If we refer back to my previous slide on the 4 key components, what we have established so far is just 3 out of 4 components, and it's still a work in progress for us to iron out many of the issues that we face. Both of the initiatives that we implement in Histo as well as cytology are currently standalone system and not yet being integrated with the laboratory information system. And when we come to this part, it will definitely pose a great challenge for us. So where we are actually still at the infancy level because we have only implemented digital pathology at one site, one location, which is in PIL at PHKL. And here we have actually, in PHKL, we have already introduced many forms of automation at possible steps in the workflow. So say, for example, recently we have upgraded the cassette printer to a better model. We have introduced 2 slide printer at HistoLab, 1 slide printer at Cytology Lab to automate the slide printing upon scanning the barcode. And the next is that in histology, we have already introduced film cover slipping. And the next step for histology is that we want to link the H&E auto stainer directly to the auto cover slipper so that the staff do not have to transfer the rack from the auto stainer to the cover slipper. And for cytology department, we are now looking into getting automated glass cover slipper for cytology, and eventually to also link the auto stainer to the cover slipper. Yeah, these are some of the automation that we try to introduce to relieve the workload of the staff and also to minimize error, of course. Yeah. Currently, we are also not using digital pathology for primary diagnosis yet, as mentioned earlier. So primary diagnosis meaning the process of diagnosing a case based on digital image and not referring to glass slides. Our process now, our current workflow still requires us to refer to glass slides. And we are also, at the moment, we are actually adopting a stepwise approach, yeah, so that we can address all the challenges as they arise. Before we embark into digital pathology, we did not actually anticipate many of the issues that will arise. So as we go in, as soon as we started, we encounter many issues, which we have to include people from various teams to help us to resolve all the issues like network issues, IT connection issues, and all sorts of issues that we face. Yeah. So one by one, we try to address this challenge, and we try to be familiarized with digital pathology before we move on to the next phase to full implementation. Yeah. So this is our journey with digital pathology. Our journey actually started since 2021 when we started using the Roche UPath image analysis algorithm to analyze the PD-L1 assay for non-small cell lung cancer, which is a image analysis algorithm, a closed system by Roche. It was then the first scanner was placed in our lab for this purpose. This was the Roche Ventana DP200 slide scanner. Since then, we have been using this scanner to also scan our urgent IC slides. In 2023, we installed the DP system with AI in cytology to be used as a screening tool. In October 2023, we were selected as the winner of a grand challenge organized by MITE in collaboration with Tubitak to work on a project related to AI algorithm, which led us to purchase our second unit of slide scanner. For your information, MITE stands for Malaysian Industry Government Group for High Technology. Tubitak stands for Scientific and Technological Research Council for Turkey. And both of these organizations actually put together research funds for collaborative projects between these two countries. So in summary, this digital pathology journey is fairly new to us, and we are still at the learning phase, trying to understand how to implement digital pathology seamlessly into our workflow by working through all the technical challenges. So what's next for PIL? For the next phase, we hope to implement digital pathology in East Malaysia, in particular Kuching, North and Southern region of Peninsular Malaysia, in order for the central lab to be able to cover for other branches that are experiencing manpower issues for the following services, including pap smear screening, frozen section consultation, as well as telepathology consultation. Our current usage of digital pathology is probably at the range of 20% of our anatomic pathology workflow. And of course, the ultimate aim is to achieve full end-to-end DP solution. And this seems to be quite far-fetched. That may probably take us a while to get there, but we remain hopeful on this. Now, this will be my second last slide. So what are the future trends in digital pathology? So in recent years, we have seen tremendous growth in development of novel AI approaches in pathology. We can foresee there will be more and more AI tools being developed, which are scanner agnostic with open software that can accept images from different formats from different scanners being developed, and when used appropriately with human, being pathologists or lab personnel, it can promote precision medicine in cancer care. Hence, lab must be prepared to embrace these new innovation technologies. We should also foresee that more emphasis will be placed in trying to harmonize the digital pathology with the laboratory information system, as this is very crucial to be in place so that pathologists can have access to all relevant case information from one application for a holistic view instead of having to open several applications concurrently, as what they are doing right now. And with better improvement in telepathology infrastructure, hopefully it will allow more smooth and seamless referral of cases from one location to another, one hospital to the other, which will surely help to overcome the shortages of pathologists in coming years. So before I end, I'd just like to leave you all with this final take-home message, that the true value of using digital pathology system is not to replicate the microscope, but to provide ready access to digital slides from any location, innovative workflows, advancing pathology through clinical transformative solutions using machine learning and decision support tool. And with this, I'd like to thank you for your kind attention. I'll be happy to take questions if there are any.
Hi, Dr. Ng. I have question. Two questions. One question actually. So how does Premier Integrated Lab settle the evaluation for slides with unsatisfactory quality? Do you recheck it manually?
Yeah, so we will go back to the microscope. That's why I say we are not really using the DP for primary diagnosis yet. It's still as we are using it like for assistance, like just a complementary tool. Once the system is more stable, we will start to validate, and we are going to use the CAP guidelines to validate. And hopefully by then, we probably can then start to use as for primary diagnosis. That is our aim, yeah, eventually. Because now we are doing double work actually. You go through AI, but you still need to screen using the microscope, which is, yeah. But eventually we hope to streamline when all the staff are confident. That's why we need to do the validation part. Yeah.
I see. Perhaps maybe after you're done with the validations in the future, you can share the experience. You can share the experience with all of us.
Well, definitely. I hope I will get another round to share our updates when they are maybe in next year, in the coming years. Yeah. Hope to share more advice with you all.
Okay, thank you. Does anyone else have any more questions? I guess no. Okay, there's no question. There is no more questions. Thank you so much, Dr. Ng, for that insightful presentation and for thoughtfully answering the questions earlier. So I believe we all gain valuable insights into digital pathology and its evolving role in healthcare. And thank you to everyone who joined us today. Your participation made this session both interactive and meaningful. For those who wish to revisit today's discussion, the webinar recording will be available on ASOM website in about 1 to 2 days. With that, we wrap up today's webinar. Dr. Ng, we look forward to seeing you at future events. Have a wonderful afternoon, everyone.
Thank you. Thank you for having me.
Yes, you're welcome. Our pleasure. Bye, Doctor.
Bye.